Bimlakar, in the reconstruction techniques, you mentioned the last one, where you use the ileum and cecum.
Yes, sir.
I mean, how many studies have been done on that?
Just it's a theoretical option.
Oh, theoretical option.
So
Okay.
no studies are there, sir, as of now.
Bimlakar, following total gastrectomy, I know many options are there.
Yes, sir.
What do you normally follow?
Esophagojejunostomy, sir, without loop.
Roux-en-Y,
Roux-en-Y esophagojejunostomy without loop.
intracorporeal or open? Laparoscopic intracorporeal?
Most of the
or
times laparoscopically. So at times we suture, at times we use linear stapler, and very few times we use circular stapler.
Okay. Any experience of the so-called pi anastomosis, side to side stapling?
Side to side stapling, it's very good, sir. It will be wide. But if you have a good length of intra-abdominal esophagus, and if you have a little bit of more of body tumor, not the OG junction tumor, where you can cut at the esophagus level with a good margin, esophagogastric junction level with a good margin, in such cases we'll do side to side, esophagus side and the jejunum side, we'll use anastomosis. That will be a good length of anastomosis.
Because what we have seen is during laparoscopy, when you cut the esophagus, because of the pneumoperitoneum, the esophagus keeps tending to go into the mediastinum. So holding it itself is a big challenge.
Yeah, what we will do, sir, we'll put two stage sutures and we'll take out with the suture passer, we'll hold outside. So it will keep. We have one good video recently we have done with the robotic also. So it will keep in position. On either side, we'll put sutures and we'll take it out with the suture passer and we'll...
Dr. Bharat, following distal gastrectomy, what's your standard reconstruction technique?
Standard reconstruction will be a
Roux-en-Y versus simple gastrojejunostomy and jejunostomy.
Yes, sir. Roux-en-Y is the standard approach. But as I mentioned again, Billroth 2 with Braun is a shortcut. But then again, the studies say that long term, the prospectives of this particular anastomosis are again not very good.
Basically, whenever we do Roux-en-Y esophagojejunostomy, the jejunal end loop, if we leave little bit, it probably we think like it will act like a pouch and it will increase with the time.
So Dr. Nusrat from Basavatar Government Cancer Hospital. So many times we encounter large lymph node station 6. So the Japanese guidelines advocate if station 6 is positive, then you have to go for station 14B. So any experience on that?
So, as of now, we have not, only the guidelines we have suggested, but when the lymph nodes are positive, how many are we doing intraoperative frozen to check the lymph nodes? That is one question.
No, large nodes which are virtually looking metastatic.
Virtually looking metastatic nodes, then definitely we have to go for the 14 station lymph node. According to the guidelines, we have not. We don't have much experience.
And when do you do mediastinal lymph node dissection like station 110, 111 and 112?
When there is when the distal esophagus is involved in the proximal gastric tumors, then we consider doing these 2 stations.
So then total gastrectomy might not be a
total gastrectomy along with the 110 and.
So sometimes as a part of gastric section, a small part of duodenum might also be involved in a stomach. So we tend to dissect D1. So the guidelines also say station 13 lymph node dissection.
Definitely.
So it's very difficult. But what is your take on that?
We are advocating the removal of station 13 when the duodenum part of duodenum is involved, and we are going extensive D1 resections.
And any experience on, because in early gastric cancer, once the margin positive, versus in advanced gastric cancer when the margin is positive. So when do you advocate for a re-resection of margins in the both cases?
In case the margins are positive, personally I don't have an experience of it, but when there is a margin positive, it is always better to resort to the higher resectional technique.
So for even advanced cancer, do you go for
unless there are metastatic peritoneal disease, we can still proceed.
If it is beyond D1, definitely it must be infiltrating the pancreas also. If it is going on to the D2, there is no other way you have to go for Whipple's.
No, for early gastric cancer, there is a lot of evidence that re-resection will help in overall survival benefit. But in advanced cancer, I don't think there is no benefit of re-resection.
Yes, if it is early gastric cancer, there is no question of margin positivity, there is no question of re-resection, I think. If it is advanced gastric cancer, if you miss the margin or if it is a positive margin, then the question of whether to go for re-resection or not. If it is early gastric cancer, this is unlikely to have a margin positivity, obviously.
Are we talking about a scenario where there is palliation being offered, or
No, for curative.